Hello, everyone. This is the third talk of a series of talks, lectures, and discussions that we have created to enable our doctors in the community. So, whether you are a physician, pediatrician, or a community physician, family physician, to enable you to understand how to approach common hematologic problems, what are the common diagnoses, what is the treatment for common diseases, and when to know, and when to essentially evaluate patients. So, which are the conditions which need more evaluation? So, to help you do this, we have started this series, and towards that aim, the topic today is thrombocytopenia, evaluation and treatment. I'll start with concepts of cytopenia, which I had spoken about in quite depth in the approach to anemia talk, and but I will still give a few pointers on that in this one too. Essentially, the concept is that inside our bones we have the bone marrow, and this bone marrow is a factory. It works as a factory, and the factory produces blood cells. So whether they are RBCs, the different kind of WBCs or platelets, that's the end product. And like every factory, this one as well needs raw materials, and in this case, the raw materials required are iron, vitamin B12, and folate, most importantly. Of course, the factory also needs proteins and micronutrients, but most importantly, these three. These raw materials go inside, and there are workers here, which are essentially the immature cells, the precursor cells. So, erythroid precursors make RBCs, myeloid precursors make various granulocytes, monocytes. The lymphoid precursors make lymphocytes, and megakaryocytes are the platelet precursors. So the precursors are the workers in the factory. The raw materials are iron, B12, folate, and the end product are the blood cells. If we apply this concept, this logic to thrombocytopenia, then we can broadly say that platelets may be low in patients either because the factory production is down, so there's decreased production, and this can be because the raw materials are not there. Very straightforward, right? So, not so much iron, but vitamin B12 and folic acid are certainly required for platelet production. And in megaloblastic anemia, there are several patients whose platelet counts are low. Usually they're borderline low, 70, 80,000, but sometimes we see severe thrombocytopenia as well in B12 or folate deficiency. Uh, the second cause may be that the raw material is there, the workers are there, but the genetics of the workers is not good enough. Now, this is very rare. Very rarely does it happen that there are problems, that there are mutations because of which the megakaryocyte precursors just don't exist in the bone marrow. So obviously this is a congenital problem and inherited disorder, but again very rare. Uh, it's possible that the factory does not have workers, so the marrow has failed, and which is called as aplastic anemia, or the marrow is packed with bad workers, bad guys who are not allowing the good guys to make the cells, not allowing the good guys to make platelets. So these bad guys can be blood cancers, that is leukemia, lymphoma, myeloma, solid tumors such as metastatic breast cancer, etc. So either the marrow is not producing because of low raw materials, genetic issue, empty marrow, marrow packed with bad cells, bad workers, or in many patients, the marrow is working fine and it is making enough number of platelets and pushing them out in the blood, but the platelets are getting destroyed. So, increased destruction. And this is what you will actually see in, I'm sorry, the slide is getting covered by the video. What it is actually saying, showing is platelets are destroyed because of DIC, so consumption, or TTP, where platelets are just broken, or maybe immune, that is ITP, autoimmune thrombocytopenic purpura. There are also other causes of you know platelet loss in the periphery, and which is actually down here, that is hypersplenism, which means the bone marrow is fine, the blood is fine, but the spleen is large due to some other problem. The spleen may be large because of liver cirrhosis, right? But the spleen is so large, so when the blood goes inside, a lot of platelets are caught up in the spleen and they die. So that's hypersplenism as a cause of increased destruction, leading to thrombocytopenia. However, one very important thing to look at, unlike low hemoglobin, unlike anemia, when the cell counter tells you that, the hemoglobin is low, it's usually correct, it's accurate. However, there is a very unique problem with platelets. Whenever we have any patient who has thrombocytopenia, we have to first ascertain that it is really genuine thrombocytopenia. The platelets are really low. It's not pseudo thrombocytopenia. And what is this pseudo thrombocytopenia? This is found because of two problems. Okay, so this is a peripheral blood film. These are the RBCs, and this is a clump of platelets. These are platelets sticking to each other. Generally, platelets are not clumped like that. You see, these are small, separate individual platelets. That's how they are supposed to be. They are supposed to be spread out on the peripheral blood smear. However, if there is a clump, then that's one cause of pseudothrombocytopenia. And we'll come to that in detail. There is another cause which is called as giant platelet syndrome. Now, it's a very interesting syndrome because it's essentially a machine error, it's a technical error, and we see it quite commonly in India, in the eastern part of India. It's a genetic condition, it's not a disease, so these patients have no problem. It's just that genetically their platelets are larger than usual. Platelets are larger than usual. So if you look at the platelet volume, okay, the volume of the platelet, the size, if you look at the mean, the average platelet volume, that ranges between 4 to 11 femtoliters. 4 to 11. And this is coded in the software of our cell counter. Cell counter is the machine which measures, which gives you the complete blood count. So the cell counter knows that if the size of the cell is so much, count it as RBC, whereas if the size is this much, count it as WBC. And if the size is like this, between 4 to 11 femtoliters, smallest, you count it as a platelet. That's how the cell counter counts the cells based on the size, differentiates the cells. Now, what happens in these patients is they have an inheritable, a genetic mutation, because of which their platelets are larger than normal. And this is seen in about 1% of individuals. And because the platelets are large, the cell counter does not count them. The cell counter thinks, no, no, this is more than 11 femtoliter. So this can't be a platelet, this must be a dust particle. It may be a dust particle. So the platelet, the cell counter does not count it, and it gives us a false low value. So if you take the patient's blood and run it through various cell counters multiple times, you will get very varying, very weird numbers. Sometimes it will say 55,000, sometimes it will say 100,000, sometimes it will say 80,000. So it will keep on varying because it keeps on ignoring to count the larger platelets. That's the first cause. Okay. Now, obviously, the way to count these platelets is we just make a peripheral smear, and our pathology friends, they physically count the platelets under the microscope, because they're going to count the small, large, medium sized platelets. They're going to count everything. So for us to differentiate between pseudo thrombocytopenia and real thrombocytopenia, you just need a peripheral smear. Whether the pseudothrombocytopenia is caused by the platelets clumping together, again, this big clump is something that the cell counter will ignore. The cell counter will not count this. Now, why do the platelets clump? In this second cause of pseudothrombocytopenia, what happens in some patients is Some individuals, they're not even patients, right? They're normal. You take their blood in the usual EDTA tube, and that EDTA will activate the platelets so that they start sticking to each other. You see, platelet, their job is to stick to each other and form a platelet plug. So the EDTA can activate platelets in some individuals, and they stick to each other, they form a clump. This clump is very big, so the cell counter does not count it, right? As far as the software is concerned, it says, hey, this is not a cell. So all of these platelets which are stuck in this clump will not get counted. How do we avoid that? How do we know that it is because of this? Make a peripheral smear. If the false low platelet is because of giant platelets, do a manual platelet count. If it is because of a clump, collect the blood sample not in EDTA, collect a second sample in heparin or citrate, or sometimes we just do a direct finger prick and take that sample for a platelet count, right? So no anticoagulant, a direct finger prick, you can put it on a slide and count, or you can take the blood in a capillary and do a platelet count. So whenever the low platelet count is false low because of a clump, take another sample, not in EDTA, but in heparin citrate or a direct finger prick. Whenever the platelet count is false low because the MPV, the mean platelet volume, is 13, 14, 15, and hence the counter is not counting, ignoring a lot of big platelets, just do a manual platelet count, right? So this is how we first differentiate real thrombocytopenia from pseudo thrombocytopenia. Now, once you've ensured that yes, a patient who is with you has real thrombocytopenia, you have to start thinking of what could be the cause. You will look at the hemoglobin, you will look at the WBC, and if those two cell lines are normal and only platelets are low, your first thought usually will be, hey, maybe this is dengue fever, right? Because that's common in our part of the world, and more often than not you'll be right. If you suspect that, yeah, this patient has fever, body ache, looks like viral fever, maybe dengue fever, so let me do the blood test, let me do NS1, IgG, IgM. Sure, no problem. However, if you remember in the previous talk also, I had introduced a concept called high risk cytopenia. You have to look for a thorough, you have to do thorough examination for the hematopoietic system. And hematopoietic system is not just bone marrow and blood, but it also includes lymph nodes, liver, and spleen. So ensure that there is no lymphadenopathy, that there is no hepatomegaly, splenomegaly, right? Ensure that peripheral smear is seen by a pathologist, that there is genuine thrombocytopenia, there are no clumps, the RBCs are normal, they are not broken. Schistocytes, because then it will mean schistocytes, anemia, low platelet means TTP, thrombocytopenic, right? Thrombotic thrombocytopenic purpura, right? So you have to ensure that the WBCs are fine. And if you think that no, this is not dengue, this is ITP, I'll just give a trial of steroids, don't do that. Don't do that. First, you have to rule out leukemia. If you are thinking of anything other than TTP, anything other than dengue fever, and if you're thinking of ITP, please don't give steroids, right? Please don't give steroids. You need to do a bone marrow. You have to rule out other problems before you give steroids, because steroids can mask leukemia. It can mask lymphoblastic leukemia, and you may miss the diagnosis. So these are the concepts of evaluation of low platelets. We of course have to take a history. We have to check how were you few days ago, when did the problem start, right? Are there any symptoms of anemia along with this? You know what the symptoms of anemia are, right? Have you been having recurrent infections? Do you have bleeding? Is there bleeding which is mucocutaneous? So low platelets will lead to bleeding from the mucosa. So oral mucosa, genitourinary, gastrointestinal bleeding, bleeding PR, and cutaneous. So petechiae, purpurae. You also need to ask, when did these symptoms start? Have they been there for some time? Have they come and gone? Some people will say, yeah, yeah, doctor, I had similar problems 10 years ago, right? So these details in history are important. Look for B symptoms. These are very important for us. And B symptoms are essentially fever, weight loss, and night sweats. And if these have been going for 6 months, then we have we have to have a high index of suspicion for a hematologic malignancy, especially lymphomas, etc. So this is the history that we take, and of course you have to do a system review. You have to check, do you have cough, cold, fever, do you have a cardiac problem, a GI, genitourinary problem, diarrhea. You have to do overall system review, because it's not always dengue and ITP. There are multiple causes of thrombocytopenia, and we don't want to delay the diagnosis by missing basic history. So, brief 5 minute or less history, which covers the major aspects of differential diagnosis. Clinical examination is very simple. You look for pallor, jaundice, you look for foci of infection. If there is cough, you auscultate the lungs. You look for bleeding spots, right? And lymph nodes, liver, spleen. That essentially is all the clinical examination in hematology. And we very quickly move on to a complete blood count on an automated cell counter. Look at the RBCs, the platelets, the WBCs. Look at the differential. Request your pathologist to do a peripheral smear to see whether genuinely platelets are low, whether there are any atypical cells, there's malaria, whether there are schistocytes. Is the peripheral smear normal? Okay. Now, once you have looked at all this, then you have to decide what are you going to do. Okay. Anything else needs to be done, or is the diagnosis made? If there are any specific tests which are required, if it is anything additional, lymph nodes, liver, spleen, please do thorough blood tests. Do serum LDH. Remember, LDH is an intracellular enzyme. What that means is lactate dehydrogenase is inside the cells, and when the cell breaks, this LDH comes out and becomes serum LDH. Okay, what that tells you is if the serum LDH is high, that means the cells are breaking. The cells are breaking. And what are the common causes of cells breaking? Vitamin B12 deficiency. The cells don't mature and they may break in the bone marrow. Second, cancers. So, leukemia, lymphoma. The cells are multiplying very rapidly and they are dying also very rapidly. And when they die, they release the cytoplasmic LDH into the serum LDH. And lastly, specific to low platelets, you have to look, high LDH will tell you whether the platelets are being broken in diseases like TTP, because in TTP along with platelets, RBCs may also break, right? So if you feel there is anything iffy, please do these specific tests. Look for serum LDH, see if the LDH is high or normal. Look at the liver, look at the spleen, and if you think it's autoimmune ITP, you may choose to do a direct Coombs test, which will help you understand if there is autoimmunity against the RBCs also, not only platelets, also against the RBCs it can happen. If we suspect that it may be some kind of a cancer, then we do the biochemistry test called as tumor lysis markers, which are parameters which increase or decrease if the cancer cells, any cells, are dying rapidly, right, breaking rapidly. So along with LDH, uric acid, calcium, phosphorus, potassium, etc. So these are some additional tests that we may do in patients who have any atypical problem, right, where we feel, hey, maybe it's not dengue. Okay. And then ultimately, like before, you have to think whether this is high risk cytopenia or just dengue or dengue like viral fever. And for that, if it's just platelet or along with platelet, hemoglobin is also low. Along with platelet, WBCs are low or high. Okay. Are the other cell lines normal or are they also affected? Is this the first time this has happened or it is recurrent? Right? then don't assume dengue every time. Maybe it's something else. Maybe it's ITP, right? Is If it's dengue fever, then the platelets will usually stay low for about 2 weeks. But if they remain low for more than 2 weeks, then unlikely to be dengue fever. You have to start thinking of something else. You have to start thinking maybe it's a marrow issue, maybe it's a leukemia, maybe it's ITP, right? So prolonged cytopenia, platelets remaining low for unusually long, are the rest of the organs fine? Have the lymph nodes swollen? Because sometimes in leukemia, lymphoma, the bad cells will infiltrate the lymph node, liver, spleen, and we will see lymphadenopathy, hepatosplenomegaly. If you feel initially that, hey, low hemoglobin, WBC platelet, maybe megaloblastic, I have given treatment, but there's not much response, or your pathology says maybe there are atypical cells. Now, that's a very important trigger. When our pathology friends tell us that, I'm not sure, but there are some atypical cells, some atypical WBCs, don't take that lightly. We have to rule out a malignancy. We have to rule out a lymphoma or a leukemia, right? Or they say that the WBC differential is not normal. I'm seeing a left shift. I'm seeing some immature WBCs. I'm seeing myelocytes, metamyelocytes, which normally we don't see so much in the peripheral blood. They are all only in the marrow. If they are coming out of the marrow into the blood, if the immature WBCs are coming out, what is pushing them out? Is the marrow healthy? Is the factory normal? Yeah. And sometimes you just get recurrent hematology problems like recurrent infections. So there is a WBC problem as well. So if any of this is happening, that's a high risk patient. Don't ignore, evaluate further, right? Do proper blood tests, do bone marrow exam. If there is any suggestion of a malignancy, we even go ahead and do a PET CT to look for lymph nodes, etc. So that's the concept. And how do you actually manage your patients? Right now, you have a patient in front of you in your clinic or in your ward, somebody is admitted. How are you going to manage, evaluate, and treat these patients? Now, most importantly, if the platelets are borderline low, which means between 100,000 to 150,000, so 1 lakh to 1.5 lakhs, maybe we don't need to get very aggressive in evaluation. But if they are going below 100,000, or that is below 1 lakh, you have to figure out, you have to try to find out what's happening. If that is the case, okay, you have to see, is this the first time this platelet is low? Especially for patients who get admitted. Quite often what happens is we get a referral from, say, the ICU saying, we have a patient with low platelets, and please come and tell us and what to do. At that point, the first thing that we do is, all right, when did he or she get admitted? And if they say, no, 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 got admitted 10 days ago with pneumonia, then I'm going to go back and see what was the platelet count at admission. That is very important, okay? Because if at admission, in patients who are admitted, if the platelets were normal at that time, okay, and it's only after a few days it has gone down, then maybe the bone marrow is normal. Maybe this drop in platelet count is secondary to DIC or secondary to some other problem. Okay, so that's the thought process. It's not diagnostic, but that's the thought process. So if I see a patient in the ward with low platelets, less than a lakh, that's 100,000, I will first see what was the platelet count at admission. If that was normal, right, and I will also look at the other cells, so WBCs, etc. So if WBCs right are normal, previous hemoglobin is okay, and only after a few days platelets have dropped, maybe it's not a marrow problem. However, and especially, if it's ICU, ventilator associated pneumonia, sepsis, and I see that the WBCs are going up and coming down and left shift, and yeah, this looks like high WBC count due to sepsis, and maybe the platelets have dropped due to DIC, sepsis, right? So just this clinical profile guides me in making my provisional diagnosis. I will also do dengue test. If I suspect DIC, I will do, the usual DIC tests. Sometimes patients who are admitted later on, their platelets can go down because of a particular disease called as HIT. So heparin induced thrombocytopenia. What that means is our nurses and we use heparin to flush our IV cannula. So we use heparin to flush peripheral lines, intraarterial catheters, central lines. Now this heparin can react with certain proteins PF4 on the platelet, and that can create antibodies and lead to a drop in platelet count. So initially platelets were okay, they are dropping later, maybe sepsis, maybe DIC, maybe heparin was given, and that has led to hit. I will also do a system review, look at the neurology, see if this is TTP coming on, what exactly is happening. Now, if any of these are positive, then I treat those conditions accordingly. So you see, in DIC, in HIT and TTP, low platelets are a secondary problem. They are not the primary problem. For these, you have to treat the DIC and the sepsis properly. Of course, for TTP, you have to give TTP specific treatment, but essentially the diagnosis, drives the treatment, and I will treat that properly. However, if any of these is not positive, then I'm going to say, okay, I don't know what's happening. I want to look in the marrow. I want to ensure there's no aplastic anemia, there's no leukemia. I'll tell them, hold on to the steroids. Please don't give steroids unnecessarily. Let me first do a marrow. Let me see whether the bone marrow is normal, whether the factory is normal. Okay. So approach, if initially platelets good, no hepatosplenomegaly, no lymphadenopathy, look for secondary causes. Secondary causes are not there, dengue, etc., HIT, etc. Do a marrow. All right. What about if the platelets were low at admission, or in your clinic the patient comes with low platelet count? Of course, you're going to do dengue test first. In our geography, this is the first thing that you're going to look at. And if dengue test is positive, NS1 positive, etc., you're going to treat as dengue. You're going to give fluids, antipyretics, etc., etc. And if the platelets recover within 2 weeks, great, nothing to do. It was dengue fever, recovered. If the platelets don't recover in 2 weeks, that's where then you have to look further marrow exam to rule out again aplastic anemia, leukemia, etc. Now, in the beginning, if the dengue comes negative, all right, you may still feel, hey, maybe this is dengue-like viral illness. Yeah, the dengue tests are negative, but maybe, it looks like dengue-like. Sure, why not? But look for lymph nodes, liver, spleen, do an LDH, do a good peripheral smear examination. If all of that is fine, sure, you can have a provisional diagnosis as a dengue-like viral illness. However, if the platelets don't recover in 2 weeks, and any which way, don't give steroids unnecessarily. If they recover in 2 weeks, great. If they don't, go ahead and do a bone marrow exam. So that's the approach. If it has been normal in the beginning, then came down, look for secondary causes. If the patient presents with thrombocytopenia, rule out dengue and dengue-like illnesses. Avoid steroids, don't give steroids, it will mask a diagnosis of lymphoblastic leukemia. If suspected dengue-like illness, recovers in 2 weeks, great, nothing more to do. Does not recover in 2 weeks, do marrow exam. All right. Now let's come to some details. Okay. What is this low platelet count in dengue? How does it happen? And what we understand today is in dengue, it's the vascular endothelium which causes a lot of problems. And the platelets are activated in the blood, they stick to each other, they form clots, and there is also, the immune system eats up the platelets. So there's phagocytosis. And in dengue, whenever platelets go down because of these reasons, you just have to wait and watch. They recover in 2 weeks. There is good data to show that steroids or IVIG do not help in faster recovery of platelet count. So in clear-cut dengue, do not give steroids and IVIG without doing a marrow. When to do a marrow? If the platelets are not recovering in 2 weeks, right? And or if there are any other conditions of high risk cytopenia, like I told you, liver, spleen, lymph nodes, more than one cell line, atypical cells, blah blah blah. In these patients, you should do a marrow. Now you have a patient who looks like dengue fever, maybe even NS1 was positive, and it's been 2 weeks, from the onset of symptoms of viral fever, but the platelets are still low. There's prolonged post-dengue thrombocytopenia. What are you going to do? Okay, how to handle? Now, such patient, proper dengue fever, but taking long time to recover. We divide them into unstable patient and stable patient. The approach is very different. In an unstable patient, and what do we mean by unstable? Which means that clinically the patient is not improving. We know the phases of dengue. We know that patient should improve in 2 weeks, but they are not improving. They are persistently vomiting. They are dehydrated. Abdominal pain is a very major sign. Okay, there's lethargy. They are looking restless and sick. They are bleeding. Usually in dengue, we don't have bleeding even if the platelets are low. If they are unstable, they are pale, cold, not good perfusion, right? Urine output goes down. That's an unstable patient. That's not uncomplicated dengue, that's a complicated dengue fever. In these patients, platelets don't recover. If they don't recover, you look for sepsis, you look for DIC, you look for hemophagocytosis, because dengue can trigger these, right? And if anything like this is there, go ahead and do a marrow. Ensure that we are actually not missing a leukemia which is causing sepsis. Okay, in a stable patient, if platelets don't recover in 2 weeks, so it's all right, eating well, drinking well, doesn't have cold clammy extremities, no vomiting, no abdominal pain, liver function is fine, neurology is fine. Stable patient, yeah, sometimes take a bit longer. Maybe just do some DIC profile, do a ferritin for hemophagocytosis, and wait and watch. And you can also decide at that point that no, it's been more than 2 3 weeks, I want to do a marrow. Yeah, sure, but you can wait. But if you don't want to wait, do a marrow. If the marrow is normal, you can say, okay, maybe this is ITP and not really dengue. Maybe we have to change our diagnosis, revise our diagnosis, and we are now going to treat this patient as ITP. Or sometimes you may find that what you thought was dengue actually has underlying leukemia. Okay. There's one question which we get asked very often. What about papaya leaf extract? There are tablets, caripil and other tablets, and should we use them in dengue fever? Um, sure. There is some data, mainly preclinical data, and certain hypothesis as to how papaya leaf extract helps to improve the platelet count in dengue faster. And there is some small data, essentially from case series, etc., which says, yeah, it may improve the platelets faster. How much to give, how long to give, I don't know. There are no clear guidelines. There is no randomized control, large randomized control trial. We don't have. But if we are giving this, and as far as we are aware, there are no major side effects. So, sure, you could give a try of caripel or papaya leaf extract. Probably it's safe and it may help, but that's the extent of our knowledge. So that's dengue. We come to the second common cause of low platelets, which all of you encounter, which is called as ITP. Mind you, the name has changed from idiopathic to immune. So we call it immune thrombocytopenic purpura. We don't call it idiopathic because now we know the cause. We know the etiology is autoimmunity. So what about ITP? We know this can happen in adults and children. It's an autoimmune problem. Bone marrow is usually normal in these patients. The cellularity is normal. There are no abnormal cells. There's no leukemia. Essentially, we do a marrow just to rule out other diagnosis, right? And in these patients, the platelets are low, generally less than a lakh. Sometimes they may come with 2,000 platelet count, 10,000 platelet count. They may present with bleeding, right? And based on whether this is the first episode or recurrence, we call ITP as newly diagnosed, persistent, or chronic. So newly diagnosed patients mean those who are less than 3 months of diagnosis. 3 to 12 months is called persistent, and if the platelets remain low for more than a year, then we call it chronic ITP. Now, why this is important is because when ITP happens in children, in two-thirds, up to two-thirds of patients, it may spontaneously revert. So from acute, it may go to persistent and revert, and platelets become normal even without. So we give some treatment, and later on they don't need treatment, which means they don't go into chronic phase. Okay, so in children, pediatric ITP, they will present with low platelets. We of course treat them, and I'll tell you when we treat them, what are the indications for treatment, and later, but they may not need chronic treatment because it reverts in up to two-thirds of children. However, in adults, up to two-thirds of patients will not revert, they will become chronic. So that's when we say, hey, it's for more than a year, it's chronic. And if there is an underlying condition like SLE, right, another autoimmune problem which is leading to ITP, then we call it a secondary ITP. If there is no underlying condition, we call it primary ITP. Remember, for us to diagnose ITP, no hepatosplenomegaly, lymphadenopathy, bone marrow normal. We have ruled out liver cirrhosis, hypersplenism, etc. Everything is normal. It's just that the platelets are being destroyed by autoimmunity. Okay. Now there was a very interesting discovery in this disease, a couple of decades ago, and what was found that you see the marrow, which is the factory, right? And there is a chemical, there's a hormone called thrombopoietin. Like for hemoglobin, we have erythropoietin for hemoglobin. We have thrombopoietin for platelets. So thrombopoietin goes to the marrow and stimulates the marrow to make platelets. Now, what we have seen in ITP, the research shows that actually if the platelets go down, the body should make more thrombopoietin so that it can stimulate the marrow even more to make more platelets, right? Compensatory. But that may not happen. So many patients of ITP may not have good production, good levels of TPO, thrombopoietin, in their body. And hence, it was hypothesized that what if we give artificial thrombopoietin? Like we give erythropoietin injections for patients on dialysis. Similarly, what if we give thrombopoietin, artificial thrombopoietin, right? Thrombopoietin analogs. And that has shown to work beautifully. And that has shown that it can improve platelet count. But which patients should we treat? Because there are many chronic ITP patients who have platelet count of 60,000, 70,000. We don't treat them. Remember, nature has given us huge number of platelets. We don't really need 100,000, 200,000, 3, 4 lakh platelet. We don't need. For us to live, to be safe, 20, 30,000 platelet count is enough. And ITP is an autoimmune problem. Many patients, it's a lifelong problem. So whom should we treat? How long should we treat? Remember, majority of the patients actually do not bleed because the marrow is making huge number of platelets, and these platelets come out of the marrow into the blood and they stop the capillary bleeding, and the immunity destroys it. But the marrow keeps on making huge numbers of new platelets. So that's why majority of ITP patients don't bleed. And there are only two conditions where patients bleed. Okay, only two conditions. If we try to predict which patients will bleed, then those in whom platelet counts are low for a long time, so prolonged thrombocytopenia, first. Second, those who have mucosal bleeding. So if they have petechiae, like this photo shows on the skin, that's fine, that's not high risk bleeding. But if somebody has oral wet purpura, what we call, right, bleeding in the mucosa, if they have gastrointestinal bleeding, that means GI mucosa, or genitourinary bleeding, so hematuria, okay, mucosal bleeding is a high alert symptom. These patients who have mucosal bleeding can bleed in the brain. They can have sudden intracranial bleed. Okay, so if the platelet counts are not very low for very long, and if there are no mucosal bleeds, then these are patients who have a very low risk of life threatening bleeding like intracranial bleeding, right? So these are the wet purpura, what I told you, mucosal bleeds. If somebody has this, that's bad, right? And of course, age is also critical, because as age increases, the risk of bleeding increases. Okay, so patients who have very low prolonged platelet counts, wet purpura, age, and if they have hypertension or they've had a stroke or a bleed in the past, these are the patients who are at a high risk of bleeding. Others are not. So essentially, what we do is we figure out who is at a high risk of bleeding. How much should we treat? How aggressive should we be? We don't admit and treat every patient equally. No, not at all. What we see is, let us first figure out, just a minute. We first figure out which patient should be treated, and to do that, essentially what we do is, I'm going a bit ahead here, right? We will initially decide if the platelet count is more than 20,000 or not. If the platelet count is more than 20,000, they have a very low risk of bleeding. If the platelet count is more than 30,000, they may not even need treatment. Okay, so you need to understand that the target platelet count in ITP, the target platelet count is 30,000. We are not trying to reach 100,000. So many times patients come to us, sir, the platelet count is still low. You have been treating for 2 months. It's still 50,000. We say, yeah, our target is 30,000. Anything more than 30,000, if I give you unnecessary medicines, you are only going to have side effects. You're only going to have adverse effects of the medicine and unnecessarily waste money. So the goal is 30,000. Platelets more than 30,000, no bleeding, no risk factors for bleeding, we may not even treat. And even when we treat, as long as it is above 30,000, you're fine. We are not trying to target 100,000 or 200,000. So that's the first. 30,000, decide if you want to treat. Less than 30,000, yes, treat. Less than 20,000, wet purpura, admit and treat. Okay, so less than 20,000, but no wet purpura, no other mucosal bleeding, no hypertension, young patient, we don't have to admit. In those patients, on outpatient basis, we will start steroids if the platelets are less than 30,000. However, in those who have wet purpura, very high risk of bleeding, less than 20,000 platelet count, we admit and we start IV immunoglobulin, IVIG. Okay, we won't just start steroids for patients who have a high risk of bleeding. We will give IVIG because that works the fastest. Steroids take about 4 or 5 days usually to start working. IVIG will work in 2-3 days. Okay, and we start these treatments, and then because it's an autoimmune problem, probably lifelong for many patients, we have to use second line treatment. So we may use rituximab, other immunosuppressants like azathioprine. Dapsone interestingly works beautifully, a leprosy medicine. So MMF, dapsone, danazol, azathioprine are usual second line agents. Nowadays we do splenectomy very rarely, only in emergency situations or unstable patient who has failed everything else, we go ahead with splenectomy. And of course, to keep the platelets artificially up, because until your steroids, rituximab, IVIG and all that works, you have to push up the steroid. So for that we give thrombopoietin analogs. So eltrombopag, romiplastin. These are the two available in India at the moment. So that's the logic. Okay, more than 30,000 may not even treat. Less than 30,000 treat. Less than 20,000 with wet purpura, other high risk features, admit and give steroids, IVIG, Retux, etc. If not, having any high risk features, treat with steroids on the outpatient basis. use second line for long term treatment, because you can't give steroids for long term, right? Now, there is a concept which has come over the last few years, that earlier we used to give steroids, then azathioprine. If azathioprine fails, you go to MMF. If that fails, you go to something else. But increasingly, people have realized that maybe instead of trial and error, one drug after another, why don't we combine drugs so that more patients will benefit, right? So there was a paper for a regimen called total therapy, and this was a wonderful paper. And in this, you of course give steroids because autoimmune problem. So we start with dexamethasone; it works the fastest. Add thrombopoietin agent and give rituximab. Okay, low dose rituximab once a week, and total therapy. 90% of patients have a good response. 90. Normally, if you give single agent steroid as about 60-65% of patients will have good response. One third of patients will not respond. But with total therapy, 90% of patients have a response, and most of them have a complete response. That means platelets go over 100,000, they go over 1 lakh, and for 4-5 months they may not need any more treatment, right? So you use this for a month, and beyond that they may not need anything. Okay, now I'll tell you what our approach is amongst all of these options. What do we do for diagnosis? First time the patient presents, we rule out dengue, do a marrow, which should be normal. We rule out HIV, HbCG, HCV, do an ANA profile as an autoimmune panel. We decide whether it's newly diagnosed, persistent, or chronic ITP, and then we look at the platelet count, of course. So less than 20,000, newly diagnosed patient, high risk for bleeding, having wet purpura, etc., we will admit. Everybody else we manage as an outpatient. Once you've confirmed platelets more than 30,000, we can even wait and watch if they don't have other risk factors. How do we wait and watch? We do platelet count weekly for 1 month, monthly for 3 months, and then 3 monthly lifelong, because they can have a late drop in platelet count. It's an autoimmune condition. It can recur after 5 years. So lifelong they need monitoring. However, if the platelets are below 30,000, okay, severe bleeding, yes, no. If there is no severe bleeding, pediatric patient, we start with steroids, dexa followed by prednisolone, and most of the patients will have long-term remission. I mean, two-thirds may not even recur, right? They don't go into chronic. Not all of them, all of the children go into chronic phase. Some will go into chronic phase, and then we will add azathioprine, etc., as a steroid sparing agent, so that we don't give steroids for too long. What about adults? Low platelets, no severe bleeding. Adults, sure. Here we check affordability. If the patients can afford, we offer total therapy, because most of the patients respond, right? You don't have to worry. You give Dexa, Eltrombopag, and rituximab, and if they can't afford, give something similar to what we give to children, right? Now here we prefer total therapy because most of the adults will go to chronic. Most of the adults are not going to have spontaneous reversal. Okay, they will go to chronic, so might as well give them total therapy. If they can't afford, we give steroids, dexamethasone followed by prednisolone, and then add second line. Here it's second line, I'm sorry, because the video it's not visible. So second line we will add azathioprine, danazol, sometimes dual agent. This is how we manage patients more than 30,000, less than 30,000, no severe bleeding, pediatric adult, and less than 30,000 with life-threatening bleeding. So somebody comes with intracranial hemorrhage, hematemesis, lower GI bleeding. In those, we give IVIG. All right. And sometimes we have to do an emergency splenectomy because nothing else works. Okay. The goal, like I said, in ITP is keep platelets more than 30,000. Don't try to target 1 lakh, 2 lakh, etc. And add Eltrombopag or romiplostim in between for a rapid response until your immunosuppressants start working. So that's it for this talk. Feel free to reach out if you have any doubts, any questions, or if you want to discuss your patients. Thank you so much.